The next specimen is a hysterectomy specimen, which usually comes to us with a history of a woman who is postpartum, but during delivery it was found that after delivery of the baby there was continuous bleeding and the placenta could not be delivered. Due to extensive bleeding, a hysterectomy would have been indicated, and this would lead to the specimen that we have. So the specimen is actually kind of bivalved. So this is the serosal surface on both sides here with some ink, some yellow ink on the surface. And then when it is opened on the left and right sides, and after sectioning, we see the myometrium. But then as you go towards, this is probably the anterior surface, there is a more friable tissue here, which is actually the placenta embedded in the wall of the uterus. And if you look in another section here, you can see placenta with only about a centimeter region of myometrium that is remaining after the invasion. So this process is called placenta accreta, and it often leads to a hysterectomy due to the inability to deliver the placenta. This problem or disease can be associated with multiple predisposing factors. One is a previous cesarean section where there may be an area of C-section scar which has decreased myometrium present. It's more common in placentas that implant in the lower uterine segment, or those that have placenta previa. It's also more common in women who've had multiple instrumentations of the uterus, including curettage procedures. When we evaluate these Accreta specimens or hysterectomy specimens, we're trying to evaluate how deep the placenta invades into the uterine wall. So there's several stages of invasion. The first would be just superficial invasion into the superficial myometrium, which is not the case here. The second stage would be invasion into the wall up to 75% of the thickness. The third stage would be extension to the serosa, and then the last stage would be extension out of the serosa and into surrounding viscera.